Hello friends, welcome to a new chapter today. In this chapter we are going to learn about head and neck. Okay, so in this head and neck chapter, first we will see about the carcinomas. Okay, so first, what is the most common carcinoma? Most common carcinomas in the head and neck is carcinoma of oral cavity. Most common mutation associated with the head and neck cancers are P53 is the most common mutation associated with head and neck cancer. Most common site of head and neck malignancy is tongue and lip is the most common site associated with head and neck malignancy. Most common histopathological thing which is associated with head and neck cancer is squamous cell carcinoma is the histopathological factor which is seen in head and neck cancer. Okay, then we have most common type of head and neck cancer in India is carcinoma buccal mucosa, followed by carcinoma in the anterior tongue, followed by carcinoma of lower alveolus. What is the most common pattern of spread? Most common pattern of spread is local extension is most commonly seen, and regional lymphatic spread is seen. First local extension and even regional lymphatic spread is seen. Most common site of metastasis is in the lungs. Most common lymph nodes involved in the metastasis, that is most common lymph node metastasis is seen in carcinoma tongue. Okay, least common lymph node metastasis is carcinoma lip. Bilateral lymphatic spread is seen in lower lip, supraglottis and soft palate. So most common mutation is P53. Most common site is tongue and lip. Most common histopathological is squamous cell carcinoma. Most common type in India is carcinoma of buccal mucosa, anterior tongue and lower alveolus. Most common pattern of spread is local extension and regional lymphatic spread. Most common site of metastasis is present in lungs. Most common lymph node metastasis is in carcinoma tongue. Least common lymph node metastasis is in carcinoma lip. If you see, bilateral lymphatic spread is present in lower lip, supraglottis and soft palate. Then what is the investigation of choice? Investigation of choice is edge biopsy. Investigation for staging, if you see, that is MRI. Investigation of choice is edge biopsy and investigation of staging is MRI. Then what is the most common flap used in head and neck resection? Most common flap used in head and neck reconstruction is, we have pectoralis major myocutaneous flap, which is based on the pectoral branch of thoracoacromial vessels. So most common flap used in head and neck reconstruction includes mainly the pectoralis major myocutaneous flap, which is based on pectoral branch of thoracoacromial vessels. Now, what are the risk factors of carcinoma oral cavity? The risk factors mainly include, we have tobacco smoking, use of pan masala, ill-fitting dentures, Epstein-Barr virus infection, alcohol, jagged tooth, sharp tooth, syphilitic glossitis, poor infection, then betel nut or areca nut chewing, Plummer-Vinson syndrome, HPV infection, that is human papilloma virus infection. So all these are the risk factors which you see in carcinoma oral cavity. Then what are the conditions which are associated with malignant transformation? These are important. So there are three types of lesions. The high risk lesions in the malignant transformation, the high risk lesions include erythroplakia, speckled erythroplakia, leukoplakia and chronic hyperplastic candidiasis are mainly seen in high risk lesions. Then medium risk lesions include, we have submucosal fibrosis, syphilitic glossitis, Plummer-Vinson syndrome are seen in medium risk lesion. What are low risk lesion? Low risk lesions include oral lichen planus, DLC and discoid keratosis congenita are low risk lesions. So conditions associated with malignant transformation, high risk conditions include erythroplakia, speckled erythroplakia, leukoplakia, chronic hyperplastic candidiasis. Medium risk lesions include oral submucosal fibrosis, syphilitic glossitis, Plummer-Vinson syndrome. Low risk lesion include oral lichen planus, DLE and discoid keratosis congenita are the low risk lesions associated with this carcinoma oral cavity. Then First we will see a few points about leukoplakia. So what is leukoplakia? Leukoplakia is a white patch or white plaque. It is a white patch or white plaque that cannot be rubbed off, that cannot be given any diagnostic name, is leukoplakia. Okay, if you see the risk factors, this leukoplakia is most commonly seen in smokers. Okay, in the smoking it is most commonly seen. It is most commonly seen in smoking, alcoholism, ill-fitting dentures, and it is seen in jagged tooth. Okay, this leukoplakia is seen in smoking, alcohol, ill-fitting denture, jagged tooth, hyperkeratosis, parakeratosis, and acanthosis. In these conditions you see leukoplakia. Then what is the diagnosis of leukoplakia? For the diagnosis we should do biopsy of leukoplakia, and here you should ask the patient to stop alcohol or tobacco intake, and the treatment is mainly treat the underlying cause. If there is alcohol, you should ask the patient to stop alcohol. If there is ill-fitting denture, you will have to remove them. Okay, so you will have to first treat the cause. If there is moderate to severe dysplasia, in order to prevent it to go into to land up into carcinoma, we should do surgical excision. Then we have something called as erythroplakia, which is also a high risk lesion. Erythroplakia is a high risk malignant lesion. So in this erythroplakia we see presence of reddish mucosal plaque. So in erythroplakia we see presence of reddish mucosal plaque. Okay, this erythroplakia is most commonly seen in soft palate, more commonly than tonsillar pillar. Okay, this erythroplakia will cause severe cellular dysplasia. It causes severe cellular dysplasia. So diagnosis is biopsy, and because it has high risk of malignant transformation, we should do surgical ablation is the treatment of choice for erythroplakia. So this is the picture of leukoplakia. Okay, where there is whitish patch here which you can see. This is the picture of reddish plaque which is erythroplakia. Okay, so these are the moderate dysplasia. So this is normally, but here see the cell nucleus has been increased a lot. So this is called as moderate dysplasia, which you see here. If you see, this is leukoplakia microscopically. Here in the excised lesion of the buccal mucosa, in the overlying squamous epithelium is thickened, and it produces gross appearance of white plaque, that is leukoplakia. Okay, here you can see the thickened epithelium, and it becomes even the nuclei becomes dysplastic. Okay, then we have something called as speckled erythroplakia or speckled leukoplakia, or also called as erythroleukoplakia. Here we have an erythematous base, and there is a white plaque along with red plaque. So in this you have two things. One, you have erythroplakia is present. Along with erythroplakia you will also see white plaque, which is leukoplakia also. Here you see there is high risk of malignancy. Let me show you the picture of this speckled erythroplakia. So this is the lesion where this is the leukoplakia and there is erythematous base. So this is called as speckled erythroplakia. Right? Next, if you see the next syndrome which is important, which is a pre-malignant lesion, is Plemy-Wilson or syndrome, or also called as Peterson-Brown-Kelly syndrome, or we can call it as Cedaropenic Dysphagia. So this is most commonly seen in middle-aged females. Okay, it is most commonly seen in middle-aged females, where it is most commonly seen in chronic iron deficiency or dysphagia with upper esophageal web. It is seen in koilonychia, that is brittle spoon-shaped nails, or it can be seen in splenomegaly, achlorhydria, and atrophic oral mucosal glossitis. So in this Peterson-Wilson syndrome you have the following features. What are they? There is chronic iron deficiency, anemia, dysphagia with esophageal web. There is koilonychia, that is brittle shaped nails, brittle spoon shaped fingernails are associated with this. There is splenomegaly, achlorhydria, and atrophic oral mucosa glossitis are associated with this Plummer-Vinson syndrome or Peterson-Brown-Kelly syndrome. Okay, then we also have then the next disorder is oral submucosal fibrosis. So what is this oral submucosal fibrosis? In this oral submucosal fibrosis, if you see, it is a pre-malignant condition. Okay, where there is formation of fibrous bands in the oral cavity. It is a pre-malignant condition with fibrous bands in the oral cavity, and there is also restricted mouth opening and tongue movement. Here mouth opening and tongue movement both are restricted. So because of that, there is increased risk of squamous cell carcinoma. This mainly occurs due to the areca nut chewing. It is associated with areca nut chewing. Here if you see, there is intralesional injection of steroid and triamcinolone should be done. But if you see, the alternative treatment for this is you can also use surgical excision with grafting can also be done as alternative treatment for this oral submucosal fibrosis, where you will see fibrous bands in the oral cavity. So these are the submucosal fibrosis which is seen in the oral submucosal fibrosis. Then after this we have something called as field catheterization. So what is this field catheterization? This is diffuse or chronic exposure. This field catheterization includes, here there is diffuse or chronic exposure to mucosa of carcinogenic substances. Whenever there is diffuse and chronic exposure to mucosa to carcinogenic substances, that will lead to the formation of separate tumors at different sites. Okay, there will be tumors present, but they are present at different sites. There are separate tumors present at different sites. If these tumors are detected within 6 months, then we call it as synchronous tumors. Okay, if these tumors are detected after 6 months, then we call it as metachronous tumors. So in field catheterization, it occurs due to exposure to carcinogenic substances. So because of this leads to the formation of separate tumors at different sites. So if these tumors are detected within 6 months, we call them as synchronous tumors. If both the tumors, there are two tumors at the different sites. If both the tumors occur within 6 months, then we call it as synchronous tumors. If both the tumors occur after 6 months, then we call it as metachronous tumors. Then what are the clinical features in the oral cavity cancer? So if you see in the clinical features, there you see a painless swelling, painless mass can be seen which is persistent. Sometimes you can even see the ulcer of more than 3 weeks duration. Sore tongue can be seen. There can be difficulty in swallowing with facial swelling and jaw swelling. Painless mass in the neck and trismus can also be seen. The investigation of choice, as I have already said, the investigation of choice is edge biopsy, and investigation of choice for staging is MRI and CT scan. The normal investigation of choice is edge biopsy. Then investigation of choice for staging is MRI and CT scan. Then we have something called as 8th Ajcc TNM classification for oral cavity carcinoma. So according to this 8th American Joint Commission for tumor node metastasis, that is TNM classification, tells us that we have this following classification. TX, tumor cannot be assessed. TIS, that is tumor is in situ. T1, in this tumor is 2 centimeters in size and 5 centimeters in depth of invasion. It is 2 centimeters in size and 5 centimeters in depth of invasion. Then we have T2, which is 2 to 4 centimeters in size and 5 to 10 centimeters in depth of invasion. Then we have T3, which is more than 4 centimeters in size and has more than 10 centimeters depth of invasion. Okay, then we have T4. T4 can be divided into T4A and T4B. T4A, it will invade the surrounding structures. If it invades the cortical bone, inferior alveolar nerve, floor of mouth, skin of chin and nose, then we call it as carcinoma lip. Okay, if it involves the cortical bone, mandible, maxillary sinus, if it involves the cortical bone, mandible, maxillary sinus and skin of face, then it is a carcinoma oral cavity. See, if the tumor invades the cortical bone, inferior alveolar nerve, floor of mouth, skin of chin and nose, then that is carcinoma lip. In carcinoma lip, it involves the cortical bone, inferior alveolar nerve, floor of mouth, skin of chin and nose. In carcinoma oral cavity, it invades the cortical bone, mandible, maxillary sinus and skin of the face. Then when do you call it as T4B? We call something as T4B. It invades through the masticator space. If it involves masticator space, then pterygoid plate, skull base and internal carotid artery, then we call it as T4B. Okay, then what are the regional lymph nodes? According to regional lymph nodes, we have NX, which cannot be assessed. We call it as N1 if the regional lymph nodes are up to 3 centimeters, then that is N1. N2A if regional lymph nodes are more than 3 to 6 centimeters, then that is N2A. N2B where you see multiple lymph nodes with more than 6 centimeters. So in N1 you see single lymph nodes up to 3 centimeters. N2 you see single lymph nodes up to 3 to 6 centimeters. In N2B you see multiple lymph nodes of more than 6 centimeters. Then we have N3. In that we have N3A where there is metastasis to lymph nodes more than 6 centimeters. And we have N3B. In this N3B, metastasis to one or more lymph nodes with clinical extranodal extension. Okay, there is metastasis to one or more lymph nodes with clinical extranodal extension is seen in N3B. Then M is for metastasis, M0 where there is no metastasis, M1 where there is distant metastasis. Then what about the treatment? If you see the treatment of oral cavity, it can be divided into, we have surgery, we can do surgery with reconstruction, or chemotherapy and radiotherapy can be done. See, in surgery with reconstruction, we will do local excision and then we will leave 2 centimeters margin. We will do, if this is the tumor, we will definitely do a wide local excision with 2 centimeters margin is left and local excision is done. So this is in surgery with reconstruction, we will do a wide local excision with 2 centimeters margin. What are the flaps used in this surgery with reconstruction? We have following flaps which can be used. One, we can use pectoral myocutaneous flap. Okay, pectoralis major myocutaneous flap can be used. This is based on pectoral branch of thoracoacromial artery. So we can use pectoralis major myocutaneous flap which is based on pectoral branch of thoracoacromial artery. Then we can use forearm flap. This forearm flap is mainly based on the radial artery. This forearm flap is mainly used to reconstruct the floor of mouth, lateral tongue, buccal mucosa, base of the tongue and soft palate. So it is used to reconstruct the floor of mouth, lateral tongue, buccal mucosa, base of tongue and soft palate. Okay, then we have one more myocutaneous flap which is called as anterolateral thigh flap. In this anterolateral thigh flap is mainly based on perforating vessels of descending branch of circumflex femoral artery. It is based on perforating vessels of descending branch of circumflex femoral artery. This anterolateral thigh flap is used in the reconstruction of lateral part of tongue and total tongue. It can be used to reconstruct either the lateral part of tongue or total tongue can be reconstructed with the help of anterolateral thigh flap. Then we also have chemotherapy. In the chemotherapy we can do the drugs which are used are cisplatin and 5-fluorouracil are the drugs used for chemotherapy. This chemotherapy can be used, there are 2 types of chemotherapy which can be done, that is concurrent chemotherapy and we have concurrent radiotherapy. In concurrent chemotherapy, the drug used for concurrent chemotherapy is cisplatin. Okay, concurrent radiotherapy can also be done. Then we have radiotherapy. So in the radiotherapy we use an external beam radiation therapy is used most commonly. So here you use external beam radiotherapy is used most commonly and the dose of drug which is used here is 60 grays for 6 weeks. We use 60 grays of dose for 6 weeks we will use. What are the complications? The complications, most common complication of radiotherapy will be xerostomia is the most common complication of radiotherapy. It can also cause other complications like mucositis, dysgeusia, osteoradionecrosis is also seen. Complications like mucositis, dysgeusia, osteoradionecrosis is seen. In osteoradionecrosis, there is caries tooth is seen in the radiation field and this caries tooth will decrease the production of saliva. Okay, in surgical reconstruction we have one more flap which is available which is called as rectus abdominis flap. Okay, what is based on this rectus abdominus muscle flap is based on the artery which is deep inferior epigastric artery, and this is used for the reconstruction of total tongue after gastrectomy. So here this rectus abdominis flap can be used to reconstruct the total tongue after gastrectomy. Okay, so this is important treatment about treatment of oral cavity. In the surgery we use different flaps, that is Pectoralis major myocutaneous flap based on pectoral branch of thoracoacromial artery. We do forearm flap based on radial artery. Anterolateral thigh flap is used based on descending branch of circumflex femoral artery. Rectus abdominis flap is used based on deep inferior epigastric artery. This is about carcinoma of oral cavity. Thank you guys for watching my lecture. In the next class we will learn about different other cancers of head and neck. Thank you.